Welcome to Ask Dr. Mingle, the Q&A series answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
And a quick reminder, as always, before we begin, you can send your questions for Dr. Mingle in a comment on YouTube or on LinkedIn, or you can email them directly to us at hello@minglehealth.com. And on the subject of YouTube comments, Dr. Mingle, you'd like to start today's session by responding to a recent YouTube comment.
Yes, Kyle. My first discussion today combines an apology, a correction, and thanks. On July 6th, the participant identified as MTNDEW99, I think that's Mountain Dew 99, submitted a comment on our Getting Denominator Data and Meeting Data Completeness Requirements YouTube publication. Mountain Dew questioned the information I presented about data completeness. Mountain Dew, you're absolutely right. I'm grateful for your correction. I'm impressed that you backed your comment up with references to the Federal Code of Regulations and the 2023 final rule publication. My apologies to all of you. As I stated, the data completeness requirements for 2023 performance year is 70%. That stands unchanged. But it does not stay 70% for the 2024 performance year. In 2024, the data completeness requirement goes up to 75%. And it's already set in the rules for 2025 at 75%. Again, data completeness criteria have not yet been set for years following 2025. In annual rulemaking, Medicare can still change those numbers already set in the rules. In my experience, I've often seen Medicare change a rule toward more leniency and have never seen them change an existing rule to make it more strict. With great confidence, the quality data completeness requirement is set for the 2023 performance year at 70%. With just slightly less confidence, data completeness is set for the 2024 and 2025 performance years at 75%. And we've yet to see Medicare's intentions for years beyond 2025, though we can confidently expect higher requirements in future years. Again, my apologies to all of you for my erroneous data, my gratitude to Mountain Dew 99 for the correction, and it's a great example of how we can be smarter together. Keep up the great work.
Our next question today comes from Jason, and Jason asks, we are a REACH ACO confused about the APM, the Alternative Payment Model incentive. Is the APM incentive going to be 5%? And were REACH ACOs at risk of not getting this at one point, but then CMS decided to keep it?
Great question, Jason. There's nothing targeted at the REACH model ACOs. You are seeing two changes right now happening to the APM incentive payment applicable to all advanced APMs. The change is a combination of a scheduled change in the incentive payment mechanism and a correction of an oversight. The quality payment program, when it started in 2017, included a 5% incentive payment for qualified participants in advanced APMs. To review how it works, there is a performance year in which you qualify. The next year, the dollar amount of your incentive payment is set based on your Medicare billings and payments. The following year, the payment year for all QPP programs, the incentive payment is made. This is the recurring pattern applicable to all aspects of the quality payment program. There's a performance year, followed by a year to collect and analyze the data, followed by a payment year. The 2022 performance year was targeted by the initial legislation as the last year to which the 5% APM incentive payment was to apply. It is to be replaced by a favorable conversion factor in the physician fee schedule to be applied starting in the 2026 payment year to qualified participants in any advanced APM. The rules inadvertently left the 2025 year without an incentive payment. This was corrected in legislation and reflected in the 2023 final rule by adding a 3.5% incentive earned in the 2023 performance year to be paid in the 2025 payment year. Again, these changes apply and would have applied equally to REACH ACOs and to all other advanced alternative payment models. All qualified participants in 2022 will get a 5% incentive bonus in 2024. All qualified participants in 2023 will get a 3.5% incentive bonus in 2025. All qualified participants in 2024 will get a favorable conversion factor on the physician fee schedule charges in 2026. Since Medicare does the QP determination quarterly, there may be a faster turnaround on the favorable conversion factor sometime in the future. We should know a lot more about this when the 2024 rulemaking cycle progresses.
And that brings us into Jason's next question for you today, Dr. Mingle. How will the APM incentive work when it is delivered through the physician fee schedule?
Great question. I'll start with a quick review of the annual dynamics of the physician fee schedule. In 1999, Medicare started building resource-based relative value units, that's RBRVUs, or simply RVUs, into the physician fee schedule, and was paying entirely on the relative value system by 2002. The physician fee schedule, or PFS, is available from CMS on their website. CMS publishes the annual schedule in January with all major changes. Then they publish quarterly updates with corrections and adjustments when indicated. The physician fee schedule, the PFS, is a large table with over 30 columns and nearly 18,000 rows. Each row represents a unique billing code, broadly described by Medicare's Healthcare Common Procedure Coding System codes, or HCPCS, HCPCS. It includes all the CPT codes you expect to use, at least in the Medicare program, all dental codes, and codes specific to Medicare for various purposes, including the quality data codes, or so-called QDC codes, that signal performance reporting. The table indicates codes that are active or inactive, payable or not payable by Medicare, relative value units for each code represented by work RVUs, practice expense RVUs, and malpractice RVUs, by location of care, specifically facility or non-facility, and a separate schedule provides geographic adjustments in each RVU type to reflect regional differences in each of those numbers. A single conversion factor applies to all payable codes. For a payable code, find the code in the schedule. Choose the facility or non-facility RVUs based on your circumstances. Apply the geographic modifier specific to your region and the RVU type, work, practice expense, malpractice expense, and then add them together. Multiply the sum by the conversion factor, which gives you the Medicare payable amount for each code. For the 2026 physician fee schedule and beyond, expect to see in the annually updated physician fee schedule a second conversion factor column. The second column will apply to qualified participants of advanced APMs. The original column will apply to everyone else. I've seen no clue yet how the advanced APM conversion factor will compare to the standard, nor if there might be some codes that might pay the same to QP, that is qualified participants, as to all other. Expect to see more details coming in this 2024 rulemaking cycle. Thanks, Jason, for the great questions.
Yeah, thank you, Jason. And our next question today is from Gloria, and it's on a similar topic. So Gloria asks, we are in an advanced APM and preparing for our 2023 quality measure submission. How will our quality scores affect our APM incentive payments?
Great question, Gloria, with an equally great answer. Your quality score does not affect your advanced APM incentive payment. Every qualified participant, QP, in an advanced APM should get, is eligible for. I just am a little bit dubious on this because Medicare does make mistakes and usually corrects them, possibly not always. They're eligible for the APM incentive payment. That's 5% in 2023 for 2021 participation, 5% in 2024 for their 2022 participation, 3.5% in 2025 for their 2023 participation, and then a higher conversion factor on the physician fee schedule in 2026 for 2024 participation. Your quality score will affect how much of your shared savings you will collect and how much of your shared losses you will have to pay, but does not affect your APM incentive payment, which is due your participating providers, that is, your qualified participating providers, just for participation, no matter how well or poorly your APM performs. There are only two requirements that determine eligibility for the APM incentive. The alternative payment model, or APM, must be an advanced APM. That, as a reminder, your APM is an advanced APM if you not only stand to gain financially from favorable cost performance, but you also stand to lose more than a nominal amount if cost performance is unfavorable. The provider, this is the second criteria, your provider must be a qualified participant, or QP, in your advanced APM. Providers are qualified participants for 2023, that is eligible for the APM incentive payment in 2025, if at least 50% of Medicare payments for professional services were for patients attributed to your advanced APM, or 35% or more of Medicare patients seen, that is by count, were attributed to your advanced APM. So there's a dollar percentage or a count percentage. If you qualify under either of those, you're a qualified participant and therefore will receive or will be eligible for the APM incentive payment.
Great. Thank you, Gloria, for the excellent question. And our next question today comes from John. John asks, Dr. Mingle, you explained that your favorite source for data for quality measure denominators is from Practice 837 billing files. But Medicare makes their applicable claims files available to alternative payment model APM entities. So it seems to me that it would be easier to access all data for our participating practice from Medicare than to reach out to each practice individually for a copy of their claim submissions. Can you explain this?
Great question, John. It would be great if it were that easy. Now, there are multiple ways to access Medicare's claim records, and you're absolutely correct that it contains a complete record of your Medicare patients' visit not only to your practice, but visits elsewhere. Medicare calls them CCLF files, or clinical claims line feed files. It represents all claims involving Medicare beneficiaries, no matter where the claim was generated. CCLF is a wonderful source of data that approximates all healthcare costs of all of your patients wherever those costs are generated, whether they're in your practice or outside of it. With it, you can generate reliable data about a broad number of things of interest, of value, including the total annual cost of care for each individual Medicare patient in your patient panel, the specific services, the diagnoses driving those services, the source of those services, and the dollar value of each element of care accessed by your Medicare patients. A leakage analysis, that is data about where your patients are going for specific services that your organization provides. But now that quality reporting for all Medicare value-based programs under the Quality Payment Program are all patient, all payer, the fatal flaw for you of the CCLF files is that they are Medicare patients only. It is technically possible to get all claims from all insurers of all the patients of each of your participating practices and providers. Now, the length and that train gives you an idea of why this is complicated. It's a monumental task with many failure points. There are no business or regulatory requirements that demand availability of global or all payer claims data. And with 900 distinct healthcare insurers in the US, each with a potential of multiple insurance products serving 50 states and 5 territories and separately regulated typically in all of those states or even sub-regions, it's easy to see how an all-payer claims is currently not practical. It is really easier to go to your practices and get a snapshot of, or excuse me, not a snapshot, but a download of all of their claims for a period of time to know, to get that data about all patients and all payers. Thanks, John.
Yeah, thank you to John and everyone else for your great questions today. And of course, thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks to all of you for the great questions. I want to be helpful and I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience, ask your questions. We can be smarter together.